We can now transition from enzyme kinetics into the high-yield concepts of pharmacokinetics and pharmacodynamics. What's the difference between these two? Well, pharmacokinetics can be simplified to how the body affects a drug. The body can affect a drug in four important ways: absorption, distribution, metabolism, and excretion. We're going to cover these four concepts in more detail coming up. Pharmacodynamics is how the drug is going to affect the body. One way to remember this is both drug and dynamics both start with D, so pharmacodynamics is how the drug affects the body. Pharmacodynamics covers the concepts of receptor binding, drug efficacy, drug potency, and also drug toxicity. We will focus first on the pharmacokinetics, or how the body affects a drug. It's important to define some concepts within pharmacokinetics. So let's go ahead and start off with bioavailability. Bioavailability, designated by the capital F, is the fraction of an administered drug that actually reaches the circulation. So the million-dollar question is, how will it show up on boards? On the USMLE, make sure you factor in the bioavailability of a drug. Many equations are going to use bioavailability, and it's an easy way to miss a point. So for IV administration of a drug, the bioavailability equals 1, or 100% available. Let's demonstrate why this is true. You're going to give a drug via a vein. That drug is going to make its way to the heart, and the heart is then going to pump it to the body. So once it gets distributed to the body, the drug may be broken down, but initially 100% of the drug gets distributed before it actually gets broken down or altered. We also have drugs given orally. For oral administration of a drug, the bioavailability equals the fraction of the drug that is absorbed and survives the first pass effect through the liver. So usually the bioavailability for most oral medications is less than 100%. Do you have any idea why the bioavailability for oral medications is less than 100%? Well, to answer this, we need to look at some anatomy. So if a drug is given PO, or by mouth, it's going to go through the gut first. It's got to make its way down through the intestines, where it's going to get absorbed. Usually 100% of the drug is absorbed, and some of it gets excreted before it hits the bloodstream. The drug that gets absorbed will make its way into the portal vein, which is going to then drain to the liver. Here in the liver, a drug is altered or metabolized through the first pass effect. The drug then goes to the hepatic vein, so we're going to continue it down here. So it's going to go to the hepatic vein, which is going to drain to inferior vena cava, which is then going to go to the heart, which is then finally going to go to the body. So notice how when a drug is given orally, we have a little bit different of a route. It's not as clean as IV, vein, heart, body. It's got to go through different structures, and one of them being the liver. So put another way, before a drug goes into the general circulation, it must pay a toll at the liver, known as the first pass effect, which is going to alter the drug in some way. Therefore, the bioavailability is less than 100%. This is going to be known as first pass effect. So we just covered the first part of pharmacokinetics, which involves the bioavailability of a drug. Now let's move into part 2 of pharmacokinetics, which is going to involve the volume of distribution. So the distribution of the drug within the body. The volume of distribution, or the V sub D, relates the amount of drug in the body to the plasma concentration. So we have a nifty little formula here, or an equation that we can draw. So the volume of distribution is equal to the amount of drug in the body divided by the plasma drug concentration. So pretty simple formula here, and then usually the volume of distribution is expressed in units of liters, so the units are going to be liters on that. Now, I've got a question for you. What are some properties of drugs that would prevent them from distributing within the body? So what are some of the factors that go into the volume of distribution of a drug? Well, let's start off with size. A large drug is less likely to cross a phospholipid membrane, so a cell membrane here, so it'll essentially be trapped within the compartment it was originally in. So we have a massive molecule here, so it'll be drug A, for example, and is big. It cannot cross this phospholipid membrane easily. On the other hand, let's throw in another drug. We have a small drug, and this can cross the phospholipid membrane easily. So it can distribute into larger spaces. It's not trapped on one side of this membrane. It can readily cross, therefore it'll distribute to larger areas. So the smaller the drug, the higher the volume of distribution. Now, what effect do you think charge has on the volume of distribution? Well, if a drug is neutral or uncharged, it's going to readily cross the phospholipid membrane. Now, we have the first drug, this is uncharged and it can cross. We have a second drug, and let's say it's charged. So drugs that are uncharged tend to be lipophilic and can distribute into larger spaces within the body. They like the phospholipid membrane, therefore they can cross it. However, drugs that carry a strong charge cannot cross the membrane as easily and are trapped within the water compartments in the body. So this one cannot cross as easily. Another way to think of it is drugs that are hydrophilic love the water, and therefore they cannot cross this phospholipid bilayer as easily, so they must stay in the body's water compartments. Now, what influence does protein binding have on volume of distribution? So let's think through it. There are many proteins found in the body. Albumin comes to mind, which is going to be made in the liver, and it's the most abundant protein in the blood. So we have a drug here, like this red triangle, and it can bind to proteins such as albumin, shielding them from being broken down, and thus limiting the amount of the active form within the body, so it'll stay in the bloodstream longer. So when a drug binds albumin, it's going to be trapped to albumin, and it'll only distribute to where that albumin originally was going to go. So it's limited to the albumin's distribution. It's going to limit the drug's volume of distribution because now the drug is trapped in the blood. This is why protein binding will normally decrease the volume of distribution of a given drug. Now let's say our patient has liver disease and cannot make albumin as efficiently as a healthy patient normally would. So here we see a histological slide of a normal liver under trichrome stain. Let's bring in this liver slide. Here we see a cirrhotic liver. Notice how the cirrhotic liver we see fibrosis that's going to stain blue, while the healthy hepatocytes will still be staining red. So the healthy liver doesn't have any fibrosis. In our diseased liver, our cirrhotic liver, we're going to see some fibrosis. So how will this liver disease affect the volume of distribution of a given drug? Well, since there isn't as much albumin in the bloodstream, the drug is going to be free to distribute to a larger area within the body. There's not that binding still. So in the case of liver disease and decreased protein synthesis, the volume of distribution would increase of a given drug. What do you think is going to happen if our patient had some sort of kidney deficiency? Well, the kidneys normally filter a lot of blood each day through the glomerulus. In a healthy patient, the filtered proteins and amino acids get reabsorbed in the proximal convoluted tubule, leaving very little protein in the urine. Can you name a renal disease that causes protein reabsorption problems? Hopefully coming to mind right off the bat is nephrotic disease. And patients with nephrotic disease normally spill proteins into the urine because the proximal convoluted tubule here cannot adequately reabsorb the proteins. This is going to result in a decrease in the proteins in the bloodstream since the body's abnormally excreting these proteins through the urine. So patients with liver and kidney disease, there will be less protein available in the bloodstream, so the volume of distribution is going to increase. So the drug will be able to distribute into larger areas within the body. They're going to be able to distribute into the extravascular spaces, thus increasing the volume of distribution. Now that we covered some characteristics that's going to affect the distribution or the volume of distribution of a drug within the body, I'm going to now present the same information just a different way. Do you remember what properties a drug would have if it had a small volume of distribution? A small volume of distribution is associated with drugs that are confined to the blood compartment, such as large hydrophilic molecules. For example, if a drug is limited to the blood compartment of the body, it will have the exact same volume of distribution as the blood volume, which is usually 4 to 8 liters, since that is the only volume in which this drug will be distributed. A medium volume of distribution is associated with drugs that distribute into extracellular space or body water, such as small hydrophilic molecules, because then they can get out of the bloodstream but not into cells yet. A large volume of distribution is associated with drugs that distribute through all tissues, including fat. These drugs are small lipophilic molecules. For example, if a drug has a volume of distribution greater than the blood volume, it means that the drug has characteristics that allow it to diffuse out of the blood vessels and into the other compartments of the body. If a drug has a volume of distribution equal to the blood volume, it means it's going to be confined to the plasma. Now we will continue on with our discussion of pharmacokinetics with the concept of clearance. Clearance is the amount of plasma cleared of a drug over time by the heart, liver, and kidneys. It's important to remember the following equation because on the USMLE, they may require you to calculate the clearance of a drug given some hypothetical values. So clearance is going to be equal to the rate of elimination of a certain drug divided by the plasma drug concentration. So clearance is equal to the rate of elimination of a drug divided by the plasma drug concentration. Now this is going to be equivalent to the volume of distribution times the Ke, which is going to be the elimination rate constant. Now it's important to note that the clearance does not refer to how much drug is cleared total, but to the volume of plasma that the drug is completely removed from per unit of time. Thus, it's going to be measured in units of volume per time, generally milliliters per minute or more likely liters per hour. So just remember the units on clearance. It's not just a certain amount that's cleared, it's going to be an amount of drug cleared from the plasma per unit of time, such as an hour. On a completely separate side note, I'm going to draw a red line here. We have another clearance equation. So there's a related formula that you're going to see in the renal section that also deals with clearance, but this will be renal clearance. Note how this pharmacokinetic clearance of a drug has a slightly different formula than this renal clearance, so be careful on test day. So do you remember what the 4 core principles of pharmacokinetics were? Remember the 4 were absorption, distribution, metabolism, and excretion of a drug. So we've already covered 3 of those concepts, absorption, distribution, and excretion, through our discussions on bioavailability, volume of distribution, and then clearance. So now let's turn our attention to the concept of drug metabolism and half-life. The half-life is the time required to change the amount of drug in the body by half during elimination or constant infusion. We can write the half-life as an equation. Under conditions of first-order elimination, the half-life is equal to 0.7 times the volume of distribution divided by clearance. So there is our equation. Now we'll deal with what first order elimination means in a few minutes. But I want you to be comfortable with this equation because you may need to calculate the half-life of a drug on test day. Another important concept to understand is a drug given at constant rate. It's going to usually take about 4 to 5 half-lives for that drug to be effectively eliminated from the body. Likewise, it takes about 4 to 5 half-lives to reach a steady state within the body. So I'm saying it takes 4 to 5 half-lives to usually get rid of a drug, or 4 to 5 half-lives to build up a steady state within the body for that drug. Now I think a practice question may clarify this concept a little better. So if you hypothetically started with 100 milligrams of drug A, how much of drug A is left after 3 half-lives? Well, we'll have to map this out. So we'll start with 100 milligrams of drug A. Now, after 1 half-life, by definition, half of 100 should only be about 50 milligrams left of that drug. So after 1 half-life, we only have 50 milligrams left. If we go through another half-life, the remaining drug in the body gets halved. So there will only be 25 milligrams now of drug A remaining after 2 half-lives. Finally, after 3 half-lives, we have 12.5 milligrams remaining. And if we continued this out to 4 to 5 half-lives, there would be 6.25 and then 3.125 milligrams remaining respectively. So essentially after 4 to 5 half-lives, there would be such a small amount of drug left in the body that we can say that the drug is effectively eliminated from the body. Now this drives home the point that it usually takes 4 to 5 half-lives for that drug to be eliminated. Let's do another quick example to demonstrate this concept. Let's say the half-life for drug X is 1 hour. A patient is given a constant dose of this drug X every hour, starting at a time 0. After 3 half-lives, before that 4th dose is actually given, how close to steady state is the concentration of a drug within the body? Now this is a tough question, so I'm going to give you a hint. The answer is going to be a percentage of the steady state. Give you a second to think about it. Alright, so the answer is going to be 87.5% of the steady state. Now let's discuss how we actually got this. we need to incorporate the concept of half-life to figure it out. Steady state means that the drug is saturated in the body and is not accumulating any more at a given dose because the elimination and the accumulation are both balanced out, sort of in a dynamic equilibrium. So what's an easy way to remember this? I like to think of steady state as a teeter-totter. So here's our teeter-totter, where the body is taking in approximately the same amount as it's getting rid of. So in and out on this teeter-totter will be balanced. Now early on, when first giving the drug, we load up the drug given side with a chubby dose, which is going to tip our teeter-totter in a direction, because at time 0, when we're first giving the drug, there's none in the body to get rid of. So our out will be light, our elimination will be light, and our accumulation will be heavy. Now, after time, since there isn't much drug in the system, now not much of the drug is being eliminated yet. However, as the drug will build up in the body's going to start to be able to get rid of the drug. So our teeter-totter will start being more balanced. And this is what steady state is. Now in the example question, we hypothetically give a drug every hour, which happens to be the half-life for that drug. This makes for some easy math, which is similar to what you might actually see on test day on the USMLE, some easy math. Back to the question at hand. After one half-life, there is 50% of the drug that is left in the body compared to steady state. So let's make up a dose. We give a square dose every hour. This is our dose. We don't even need a number. We can think of it as a square shape. So after one half-life, how much of this drug that we gave at time 0 is going to be left in the body? So after one half-life, how much of the drug is left? Well, since there wasn't any drug in our system before, one half-life, by definition, there should be half of this left in the body. So I'm just going to draw it out. There is half of this square, so now it's a rectangle, left in the body. So 50% of the drug left. So does that make sense? Now, what about our second half-life? So we gave another dose already, so now we have 2 doses within the body. Our original dose, so what we gave at time 0, it went from a full square to now a rectangle, which is 50%, to now we have to half that again to 25% of that original dose. We're kind of losing that original dose. However, we gave another dose right here. So half of that another dose that we gave needs to be taken into account. So now we have 25% and 50% of our dose making its way into the body. Now after our third steady state, that's actually the answer to this question. We're trying to figure out what is the percentage of steady state that's going to be left after our third half-life. So remember, we gave another dose right here after our calculation right here. So the very, very first dose that we gave at time 0, it got halved. Well, we need to halve that again. So this is going to be 12.5 now. Half of 25 is 12.5. We gave a dose here. At second half-life, it was 50%. Well, we need to cut that in half again. So now it's 25%. And then we gave a dose here, so we need to cut that dose in half, which will be 50%. Now, I'm no mathematician, but 12.5 plus 25 plus 50 should equal 87.5. So that is our percentage of steady state. And like I said earlier, it usually takes 4 to 5 half-lives to reach kind of the book steady state. Well, why is that? Because as we keep going on and on, we're approaching 100, but it'll take forever to reach 100. So once we kind of get up into the high 80s, the 90s, then we start saying, hey, we're pretty close to steady state, and that's our balanced teeter-totter equilibrium there. Does that make sense? All right, let's move on to dosage calculations.